interpretation of normal ECG, and by now you know all the ECG leads, all the 12 conventional ECG lead 1, 2, 3, lead AVR, AVF, AVL, and lead V1 to V6 for chest leads, right? And by now you know how to interpret a normal ECG, what are the points to see when you are to interpret an ECG. So starting from rate, rhythm, axis, P wave, PR interval, QRS complex, ST segment, T wave, and QT interval, right? So these are the points you need to see, right? And you also know the shape of normal ECG in conventional lead, like the lead 2, right? Okay. So one thing I had skipped, that is the augmented leads, right? The augmented leads like AVR, AVL, and AVF. So a very common question for you at your level, first professional MBBS, why these leads, typically these 3 leads, AVR, AVL, and AVF, are called augmented. Why these are augmented? Okay, so let us understand first, then we will move to the ECG changes in acute coronary syndrome and the ECG changes in heart block, right? And I guess by now we also remember the normal values of PR interval, right? 0.12 to 0.2 second, okay? And you also know the one small square in the longitudinal axis and one small square in the horizontal axis. In horizontal axis, it is one small square is equal to 0.04 second, and on the vertical axis, one small square is equal to 0.1 millivolt, right? So you can calculate the voltage change for any ECG wave, okay, either positive deflection or negative deflection, right? Okay. So let us begin. Why 3 leads, that is AVR, AVL, and AVF, are called the augmented leads? Can someone tell me for me the direction of lead AVF? The direction of lead AVF. Just tell me the angles. Just tell me the angle, the direction of lead AVF. How much degree? Yes, plus 90 degree. Okay. Lead AVF is plus 90 degrees. So this one is right arm, left arm, and left leg. So here is the connection, and this one is the Einthoven's triangle, right? And the direction of lead AVF is this 90 degree, right? So let us draw the leads. Lead 1, lead 2, lead 3, lead AVR, AVL, AVF. Okay. So lead 1 is the connection between RA and LA, right? This is lead 1, and this one is lead 2, which is the connection. Lead 2 is the connection between RA and LL, right? And lead 3 is the connection between LA and LL, right? Now, what is the concept of lead? So you have already known normal ECG. Now we are entering into abnormal ECG, right? We are entering into abnormal ECG, and gradually we will discuss the physiological changes, physiological basis of changes in ECG for acute coronary syndrome, number 1, number 2, heart block, and third is arrhythmia, like rhythm disturbances. Okay, so we will start with acute coronary syndrome. Okay, commonly people call it heart attack, right? So our medical terminology is acute coronary syndrome. So there acute coronary syndrome is an umbrella diagnosis, right? It is an umbrella diagnosis, and under it we have many entities like unstable angina, like ST segment elevation myocardial infarction, like non-ST segment elevation myocardial infarction, right? So we will discuss what are the ECG changes in acute coronary syndrome, right? What are the ECG changes in acute coronary syndrome, and what is its physiological basis, right? So I have already told you that ST segment elevation myocardial infarction right? So the name suggests there will be ST segment elevation, right? So while discussing normal ECG, you have known that ST segment in an ECG is the area where there is no net voltage fluctuation. So it is at the baseline, isoelectric, yes, very nice, isoelectric. So ST segment is an isoelectric line, and in a healthy individual, ST segment should be at the baseline or isoelectric, right? Okay. Now, in acute coronary syndrome, depending on the diagnosis, ST segment might be elevated or ST segment might be depressed. Okay. So that there will be a net voltage during ST segment. Okay. And you already know that ST segment corresponds to the phase 2 of fast response action potential, right? So this one is the ST segment, and you see this is isoelectric, there is no voltage fluctuation, and this ST segment corresponds to this phase 2 of ventricular action potential or fast response action potential, right? So this one is phase 0, phase 1, this is phase 2, and this is phase 3 and phase 4. Clear? So in phase 2, there is positive ion entry and exit simultaneously, calcium entry and potassium exit. Okay, so positive ion entry and positive ion exit, so that the membrane potential or membrane potential of the cardiomyocyte or ventricular myocyte remains the same, so that there is no net current flow through the membrane. So it keeps ST segment isoelectric. This is normal. Okay, normally it happens. But in case of acute coronary syndrome, ST segment might be elevated or might be depressed. Okay, so before discussing the physiological basis of ST segment elevation or ST segment depression or any changes in the Q wave, any changes in the T wave, which helps us in making diagnosis of acute coronary syndrome simply by interpreting an ECG. Right? Simply by interpreting an ECG, you can diagnose acute coronary syndrome. Maybe it is unstable angina, maybe it is ST segment elevation myocardial infarction, or it is non-ST segment elevation myocardial infarction. Correct? So let us, it is not a pathological class, but still you need to know the basics of pathogenesis behind this acute coronary syndrome. Okay. So first there is plaque disruption or erosion, thrombus formation. It leads to thrombus formation. So first there will be endothelial injury. Okay, within the blood vessel there should be an endothelial injury, right? And it will lead to thrombus formation. Okay, thrombus means blood clot, you know, right? So thrombus formation, and this thrombus lodge into the tiny myocardial blood vessel, the coronary circulation. They get stuck into the coronary circulation, right? So there is a blockage, right? And it leads to acute cardiac ischemia. Ischemia means lack of blood supply. So the tissue suffers hypoxia, right? So acute cardiac ischemia. And we divide this acute cardiac ischemia into non-ST segment elevation myocardial infarction and ST segment elevation. Okay, from electrocardiographic point of view, right? So if a thrombus lodge into the coronary circulation, there is a block in the coronary circulation, right? So some wall of the heart, maybe the anterior wall, maybe the lateral wall, or maybe the inferior wall of the heart, okay, they are deprived of blood supply. So that is causing acute ischemia or lack of blood supply to cardiac muscle. Okay, so cardiac muscle is suffering from ischemia, and if the duration is long, the tissue will be dead. Okay, the tissue will be dead. We call it infarction, right? Infarction. Ischemia means just lack of blood supply, and infarction, it causes tissue death, right? Okay, so we divide this acute cardiac ischemia into two. One is non-ST segment elevation, another is ST segment elevation. Okay, what will happen to the ECG? The patient will be complaining of chest pain, or there are many other symptoms as well. Okay, chest pain, sweating, right? Okay, but typical chest pain in the left side, it may radiate to left side of the hand, left side of the arm, inner side of the arm, left arm, and it may also radiate to back, right? This is typical presentation of acute coronary syndrome, or commonly termed as heart attack, right? Okay, so from ECG, how to diagnose this? Okay, so in ECG, either you can see a non-ST segment elevation. ST segment will not be elevated, rather ST segment might be depressed, and another way is ST segment elevation. Okay, so in both the cases, ST segment is not isoelectric, right? ST segment is not isoelectric. It may be depressed or it may be elevated. We call it non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction, that is STEMI, NSTEMI and STEMI, right? So ST segment elevation myocardial infarction and non-ST segment elevation myocardial infarction, correct? Okay. Now, if it is non-ST segment elevation, we need to check the biomarkers. Okay, biomarkers means the enzymes within the cardiac myocytes. So one tissue is ischemic, there will be tissue injury, and the proteins inside the tissue, they will leak into the blood circulation, and we can simply perform a blood test and we can measure that enzyme or protein. So biomarkers of myocardial necrosis not elevated, and if it is ischemic and necrosed, biomarkers, cardiac biomarkers will be elevated in the patient's blood, correct? Okay, so if biomarkers are not elevated, ST segment not elevated, depressed, then we will perform biomarkers. If it is not elevated, we call it unstable angina, right? And if ST segment is not elevated, but biomarkers are elevated in blood, we call it non-ST segment elevation myocardial infarction. Okay. Simply, if the tissue is injured, the content of the tissue will come out into blood, right? Say for example, hepatitis. What happens in hepatitis? It is liver cell injury. Okay, liver cell injury, hepatocytes injury. So what are the content within the hepatocytes? Hepatocytes के अंदर क्या क्या enzymes रहता है? ALT, AST, SGPT, SGOT, right? So SGPT, SGOT or ALT, AST modern term. Okay, so if the hepatocytes are injured, the enzymes within the hepatocytes, they will leak into the blood circulation, and you can simply do a blood test and you can measure the level of ALT or AST in your blood. Okay, so similarly, one cardiac myocytes are injured due to lack of blood supply, right? So the content of the cardiac myocytes will leak into blood. The enzymes within the cardiac myocytes will leak into blood. Okay, so there are enzymes like LDH, like CKMB, right? Like other proteins like troponin. Okay, they will leak into the blood, and simply we can measure those biomarkers for the diagnosis of acute coronary syndrome. Okay, so a patient of suspected acute coronary syndrome, what will you do? We will simply do an ECG, right? We will simply do an ECG. Okay, we will simply do an ECG and we will check whether it is ST segment elevation or ST segment depression. If it is ST segment depression, we will check the biomarkers. If it is ST segment depression, we will check the biomarkers. If biomarkers are not elevated, that means there is no in-depth injury to the tissue, right? If biomarkers are not elevated, and we call it unstable angina, right? Less serious among the three, right? And if the biomarkers are elevated, that means there is definitely tissue infarction, right? So we call it non-ST segment elevation myocardial infarction. Okay. Now, if the biomarkers are elevated and also ST segment elevated, we call it ST segment elevated myocardial infarction or STEMI. Most serious among the three, right? Okay. Now come to the physiological changes. Why there is ST segment elevation? Why there is ST segment depression? Why there is deep Q wave, right? Okay. So the thing is, you see, this black color action potential is of normal healthy myocardium. This black color action potential is normal healthy myocardium, correct? And this red color action potential is of the injured or ischemic myocardium. Okay. So can you tell me what are the changes happening to the action potential when the myocardium is ischemic? What do you see? Just देख के बताओ. Yes. Yes, very nice. Okay. So see, this one is phase what? Phase? Yes, diastole. Which phase is this? Phase 4. This is phase 4, right? This is phase 0. This chota sa is phase 1. Then this plateau is phase 2, right? This is phase 3 and again phase 4. Clear? Sit down. So phase 4 should be for a cardiac myocyte. Phase 4 should be at minus 90 millivolt, which is the resting membrane potential. Minus 90 millivolt is the resting membrane potential for cardiac myocyte, right? Resting membrane potential for cardiac myocyte, correct? Minus 90 millivolt. Okay. Yes. But in case of ischemic tissue, resting membrane potential is more positive, more towards positive. It is now minus 60 millivolt. Clear? Okay. So during diastole, phase 4 is basically a part of diastole. Phase 4 is basically part of diastole, correct? Phase 4 is part of diastole, and you see, you know that QRST is due to QRST complex, is ventricular depolarization and ventricular repolarization. Okay. QRST, this duration is systole, and it denotes P wave is not shown here, okay, because when the ventricle is diastole, then there is P wave. Okay. So P wave is not shown here. So we are only concerned with the ventricle. What is happening in the ventricle? So during this QRST complex, this action potential is actually happening. This is the same time frame. Both are superimposed on the same time frame. The ventricular action potential, fast response action potential, and also the corresponding ECG. So both are the same time frame, right? So this is the beginning of systole, and it starts with QRST, right? Okay. So during diastole, ischemic tissue is depolarized than the normal tissue during diastole. See this? It is minus 90 and it is minus 60. Okay, so minus 60 is more positive, towards positive. Minus 60 is positive. So what will happen during diastole? Very simple rule of electricity. From positive to negative, electricity will flow, right? So what will happen during diastole? Electric vector will flow from ischemic tissue to normal tissue. Okay? From ischemic tissue to normal tissue. What happens during heart attack or acute coronary syndrome? What happens? A thrombus lodge into the coronary circulation, and some area of the cardiac myocyte, some area of the heart is ischemic, but it's not the whole heart is necrosed or ischemic, right? A part of heart is ischemic, right? So there is an ischemic tissue and there is a normal tissue side by side, right? Ischemic tissue and normal tissue. Ischemic tissue during diastole, it is more depolarized towards depolarization, minus 60. So minus 60 is positive, then minus 90. So from ischemic tissue to normal tissue, an electrical vector will travel. Clear? Okay. Now the two basic problem with the ischemic tissue is that it cannot come back to the resting membrane potential. Okay. So once it is fired and it is not coming to minus 90. This is one problem. Okay. Once the tissue is ischemic, what is its deviation from normal tissue? Normal tissue से क्या separate behave कर रहा है ये tissue, right? So first of all, it is not coming back to after firing action potential. It is not coming back to minus 90 millivolt, which is supposed to be the action potential of resting membrane potential of cardiac myocyte. It is not coming back to normal. Okay, so somewhat around minus 60, it is getting a new resting membrane potential. Clear? And that is abnormal. Another problem with the ischemic tissue is that it is not firing up to the top, which is around plus 30 millivolt. Okay. So two problem with the ischemic tissue. It is not coming after firing action potential. It is not coming to the resting membrane potential, which is minus 90 millivolt. And number two is even during the firing, it is not going to the top where it is supposed to reach. It is not reaching at the top. Okay. The top level where a normal tissue fires is above 0. Okay, above 0, plus 30, around plus 30 millivolt, right? But an ischemic tissue, see here in this example, it is not even crossing 0. Okay, it has started from minus 60 and it is not crossing 0. Okay. So एक तो आप पूरा नीचे नहीं जा रहे हो और ऊपर से complete ऊपर भी नहीं जा रहे हो. So you are staying in between. Okay. So during diastole, it is more positive than the normal tissue. And during systole, it is more negative than the normal tissue. Clear? Because during diastole, during systole, you see it is somewhere around this plateau phase. See, this plateau phase is at 0 for normal tissue. Normal is black, abnormal is red, right? So phase 2 in normal myocardium is at 0 millivolt during systole, and during systole the abnormal myocardium is at minus 15 millivolt. So who is more positive? Normal tissue is more positive. Okay. So during systole, an electrical vector will travel from normal tissue to ischemic tissue. Clear? During diastole, an electrical vector will travel from ischemic tissue to normal tissue, but during systole, an electrical vector will travel from normal tissue to ischemic tissue. Clear? See this? So we get a diastolic vector from ischemic tissue to normal tissue, from ischemic tissue to normal tissue, diastolic vector. Okay? Ischemic tissue to normal, minus 60 to minus 90, diastolic vector. And during systole, एकदम opposite, from normal tissue to ischemic tissue. पहले ये concept clear कर लो, otherwise the remaining part will not be clear to you. Okay, everyone, okay with this? So the basic problem in heart attack, in acute coronary syndrome, is the tissue injury, ischemic tissue. And ischemic tissue behaves abnormally. Okay, and that abnormal behavior is different during systole and diastole. Both are abnormal, but the way they behave abnormally is quite different in systole and diastole, right? During diastole, a diastolic vector travels from ischemic tissue to normal tissue, and during systole, a systolic vector, it travels from normal tissue to ischemic tissue. Clear? Okay. Now, if it happens, see this. So we divide myocardial injury into transmural injury, that is the whole thickness. So we have taken a part of the left ventricle, a free wall of the left ventricle, and the reddish area is ischemic. Reddish area is not normal, right? So this is the zone which is injured, and here this is the zone which is injured or ischemic. Clear? Now what is happening? So let us concentrate on ST segment. Let us concentrate on ST segment. ST segment कौन सा एरिया है? ST segment, this it falls during systole. ठीक है, सिस्टोल के टाइम. सो एसटी सेगमेंट किस टाइम होता है? अगर आपको क्वेश्चन पूछा जाएगा कि एसटी सेगमेंट किस टाइम होता है, सिस्टोल के टाइम कि डायस्टोल के टाइम, आंसर इज सिस्टोल के टाइम होता है. ठीक है, एंड वी हैव नोन दैट ड्यूरिंग सिस्टोल क्या हो रहा है? देयर इज अ वेक्टर व्हिच ट्रैवल्स फ्रॉम नॉर्मल टिश्यू टू इस्केमिक टिश्यू. क्लियर? नाउ सी दिस. सो दिस इज अ सब एंडोकार्डियल इंजुरी, मतलब इनर साइड में इंजुरी है, इनर साइड. So this is outer side and this is inner side. So injury is at the inner side. Ischemic tissue is inner side of the left ventricular free wall. So this is your normal tissue, this light color, and this deep color is ischemic tissue. So during systole or normally during ST segment there is no net electricity flow, but here in this case, as there is subendocardial injury, a systolic vector will travel from normal tissue to ischemic tissue, and here is the location of V5, the sensor, the electrode which senses the vector. Okay, and you know that if an electrical vector travels towards the lead, it will give you a positive deflection, and if the vector moves away from the lead, it will give you a negative deflection. Okay, so here during ST segment where no electricity should travel, during ST segment there should not be any electrical vector. ST segment should be free of any electrical vector. But in case of ischemic tissue, what happens? During systole, an electrical vector travels from normal tissue to ischemic tissue. That is, it is moving away from lead V5 in this example, right? Moving away from lead V5. So what will be effect in the ECG? What will be the manifestation in the ECG? ST segment depression. Okay, as it is moving away from lead 5. So voltage will drop here. Getting my point? So similarly, if the injury is transmural, means more serious injury. Okay, so if I draw a left ventricular wall, so see, this is right ventricular free wall, interventricular septum, and so this is your LV and this is your RV, right ventricle and left ventricle, correct? And this is the wall. Now, दो टाइप का इंजुरी हो सकता है. One is the full thickness is gone, full thickness. Okay, full thickness gone. Gone means damage. ठीक है? So full thickness of left ventricular free wall damage हो गया. We call it transmural injury. Full thickness. Okay, we call it transmural injury. And another case is the inner side. Injury is in the inner side. Clear? So we call it subendocardial injury. And full thickness is transmural. Okay. Okay. So in case of subendocardial injury, you see that an electrical vector or systolic vector, it is traveling from normal tissue to ischemic tissue, normal tissue to ischemic tissue, and this is why there is ST depression. Okay, and we call it ST segment, non-ST segment elevation myocardial infarction, non-ST segment elevation. Rather, it is characterized by ST segment depression, and you by now you know what is the cause of ST segment depression, right? This is the cause of ST segment depression. Now see this, transmural, full thickness. Okay. So here you need to have some concept. So although I am telling it is full thickness, you see it is not full thickness. A strip of normal tissue is visible here. Can you see? I have drawn here full thickness injury, but still exactly it is not full thickness. Okay, you see a normal strip of tissue in between, right? Why is the case? This is because this left ventricular cavity, it is filled with what? Left ventricular cavity is filled with blood, right? It is filled with blood, and ischemia means what? Lack of blood supply. So even if there is full thickness injury, so the inner wall somehow gets some blood from the cavity, because within this cavity there is blood. Okay, when there is ischemia, if I stop blood supply to your say for example to your right hand, if I stop blood supply, if I tie a band over here and I compress it, okay, so what will happen? Blood supply will stop to your right hand. Okay, blood supply will stop to your right hand if I tie a tight band over here. Okay, so blood supply will be stopping here. Okay, so what will happen? The tissue will suffer from hypoxia, no oxygen. Okay, no oxygen. But here in this case, this thin rim of tissue, as it is in connection with blood within the ventricle, it gets some oxygen, and it usually never dies. Getting my point? So it behaves like a normal tissue in case of transmural injury. Getting my point? Okay. So again the same rule is applicable, that is during systole, a systolic vector will travel from normal tissue to ischemic tissue. So see, the normal tissue is here, the thin rim of tissue, and a vector is traveling from normal tissue to ischemic tissue. But now it is going towards lead V5. So there will be positive deflection. Okay, there will be positive deflection and ST segment will rise. Okay, so it is ST segment elevation myocardial infarction or STEMI, right? So this is NSTEMI, non-ST segment elevation myocardial infarction, and this is STEMI. Clear? Okay. Now from ECG, there are so many changes in myocardial infarction. Not only it is ST segment elevation or ST segment depression, it is also characterized by deep Q wave and sometimes changes in the T wave as well, T wave inversion, right? So all these are due to this electrical vector, the special vector which are operating during systole and during diastole. Okay, a systolic vector and a diastolic vector for ischemic tissue. Okay, systolic vector will travel from normal tissue to ischemic tissue, and diastolic vector will travel from ischemic tissue to normal tissue. Correct? So this is why all the ECG changes will be there in acute coronary syndrome. Either it will be characterized by ST segment elevation or ST segment depression or deep Q wave or any changes in the T wave flattening or T wave inversion. Okay? So there are sequence of ECG changes that you may not remember right now. पहले क्या होता है, सबसे पहले क्या होता है, लास्ट में क्या होता है, but anyway you need to remember all the changes. Okay, you need to remember that acute coronary syndrome, it may be characterized by ST segment depression or ST segment elevation or a deep Q wave or T wave inversion. T wave is usually upwards, and many a times during acute coronary syndrome, T wave might be inverted, right? So these are the changes, but the major change is ST segment change, and you now have the physiological explanation before for this ST segment change. Either it is depression or due to, or it is elevation. Okay. So now you need to identify. So this is an ECG of a patient, right? And you see the change over here. What are the changes you see here? So check lead 2. ST segment is elevated, right? Right? This type of thing. Okay. So ST segment elevation. Again lead 3, ST segment elevation. Lead AVF, ST segment elevation. Clear? Okay. So you see ST segment elevation in lead 2, 3 and AVF. Now you need to remember the wall. Which lead of the heart represents which wall? Okay. Which leads of heart represents which wall? Okay. So let us study this. If there are changes in lead 2, 3, AVF, it denotes the inferior wall of heart, right? Okay. Inferior wall of heart. If you see changes, that means ST segment elevation or ST segment depression in the lead 2, 3 AVF, it denotes the inferior wall of heart. Okay. Why inferior wall of heart? Why 2, 3 AVF inferior wall of heart? See the position. Simply draw the heart, right? And you see lead AVF is here. Okay. Lead 2 is here. And lead 3 is here. Right? So all three leads are the lower surface of the heart. So lead 2, 3 AVF denotes inferior wall of the heart. Clear? 2, 3 AVF denotes the inferior wall of the heart. If you see changes in the abnormalities in the ECG in lead 2, 3 AVF, that means the abnormality is in the inferior wall. Right? Okay. Now, the lateral wall. Okay. কোন lead হতে পারে lateral wall? Side wall? Yes. এখানে কি আছে? Lead 1. Okay. এখানে কি আছে? AVL. আর এটা আমার coronal plane, right? It is in the coronal plane. And if you see the transverse plane, lead V5 এরকম আছে, lead V6 এরকম আছে. Actually it is three dimensional, right? So in the coronal plane, and this is the transverse plane, right? So lead V5 এরকম ভাবে বেরিয়ে আছে, lead V6 এরকম ভাবে বেরিয়ে আছে, right? So যদি আমাকে three dimensional রাখতে হয়, so it will be like this, as if এটা সামনে বেরিয়ে আসছে আর ওটা, right? Okay. So এটা lead V5, V6 and V5, right? So lead 1, lead AVL, lead V6, lead V5. So all these are the lateral wall. Okay. So these things denotes the lateral wall of heart. Okay. So lead 2, 3 AVF denotes the inferior wall of heart. Lead 1, AVL, V5 and V6 denotes the lateral wall of the heart, right? V1, V2, septal wall, right? V3, V4, anterior wall. Clear? So do remember this for your lifetime. Okay. Everybody should interpret an ECG. You will be a physician, you will be a surgeon, you will be a gynecologist. Whatever be your final career, right? You need to interpret an ECG. That is the basic task of any doctor, right? irrespective of your final career path, right? It is must for everyone. You should be able to interpret an ECG, you should be able to identify a heart attack. Not only identifying an heart attack, also identify which wall of the heart is affected, whether it is inferior wall, whether it is anterior wall or septal wall or lateral wall or what. Okay? Basic thing. Now, this is an ECG of a patient who is suffering from acute chest pain. Okay, we performed ECG and you see the result. ST elevation in lead 2, lead 3, lead AVF. So it is a case of acute inferior ST segment elevation myocardial infarction. Right? Nobody will ask you the treatment. So take the patient immediately for CABG, coronary artery bypass grafting, right? Or if the facility of this is not available, okay, PCI procedure, you need to do the PCI procedure. If PCI is percutaneous intervention is not available at the setup, immediately move the patient for thrombolysis. Control the chest pain with aspirin, clopidogrel, then tablet sorbitrate, right? Control the chest pain and take the patient for PCI or thrombolysis. For pain control, morphine is also used. Anyway, nobody will ask you the treatment at first professional MBBS, but yes, it is good to know, right? So first, after an ECG, you confirm acute myocardial infarction. First target is control the chest pain, reduce oxygen demand of the heart, right? So to do this, you need to give the patient 5 mg isosorbate dinitrate sublingually. Repeat it after 5 minutes. Okay, you give a bolus dose or loading dose of aspirin, clopidogrel, atorvastatin, right? These are the drugs initially used. Okay, and even morphine is used, and definitely oxygen. Okay, supplemental oxygen is to be given to the patient, and also morphine can be used for severe pain. Okay, so once pain is controlled, take the patient for percutaneous intervention, or if percutaneous intervention is not available within 6 hours, then take for thrombolysis, or the clot, do some drug or inject some drug which will dissolve the clot, thrombus, right, like streptokinase. Okay, so this is the treatment, although no need to remember for you at your level, just identify. What do you see? Again you see ST elevation over here, lead 2, lead 3, lead AVF, in inferior or mitral infarction. Okay, what to see over here? You see ST depression, right? ST depression, where 3 AVF, 3 AVF, that is not whole thickness. Okay, this is subendocardial. Okay, non-ST segment elevation myocardial infarction. What is this? This is old. Anyway, old is difficult for you. I'm skipping this. ST segment elevation and mark Q wave in acute anterior ST segment elevation. Anterior. Okay, anterior which wall? V4, V3. Okay, somewhat in V2 also. Okay, ST segment elevation V3, V4. Okay, getting my point? V3, V4. See, anterior wall. So majority slightly septal affected. Septum is also affected because you see the changes in V2 as well, right? V4, very typical ST segment elevation. V3, very typical ST segment elevation. So it is a case of ST segment elevation, myocardial infarction. Which wall? Anterior wall. Clear? ST segment depression. কোথায় আছে ST segment depression? Which lead? ST segment depression. ST segment depression. ST segment depression. Again 3-4 maximum. Maximum ST segment depression 3-4. So you can call it anterior, slightly V2 and V5 as well, right? So ST segment depression, and biomarker is not elevated, so we call it unstable angina. Okay. So this is typical difficult because you need to study this on the same day. I will not overload you with acute coronary syndrome and heart block as well. So I'll take a separate class on heart block. What are the ECG changes in heart block, right? So I'll take a separate class next day for ECG changes in heart block. LDH, CKMB, troponin. No. Actually, for biomarkers, depends on time when the patient is presenting to you, right? After the chest pain, say for example, somebody presents to the hospital immediately within 1 hour of chest pain. Okay, someone presents 4 to 6 hours after chest pain. Okay, and someone presents on the next day. Okay, previous day उसको chest pain हुआ था तो किसी तरह वो ठीक हो गया, was not much severe. Okay, so depends on the presenting time of the patient. Okay, LDH is a biomarker which rises late but it remains. Okay, immediately we get elevated CKMB, elevated troponin. Okay, troponin is very easily available. It is available in a kit, right? So when the patient arrives in the emergency department with acute chest pain, okay, we perform ECG as well as we perform a TROP-T, which is a kit, troponin T, TROP-T. Okay, you know the skeletal muscle contraction mechanism, troponin T. Okay, so we measure troponin T. It is commercially available. Just purchase the kit, okay, and put some blood, and it will detect whether troponin T is elevated or not. If troponin T is elevated, that means it is not a quantitative test; it is qualitative test. Just it will just give you whether troponin T is there in your blood or not, in the patient's blood or not, right? Okay. So once troponin T is there, there will be two separate lines, one positive, one control. So positive and control both are appearing. There are two lines. So it is a case of acute coronary syndrome, right? Troponin T is the most popular. When it is negative, then we can proceed for